afternoon. Since Dr. Levine is on vacation, I'm stepping in and I'm going to introduce today's speaker. But before I go on, I'm a nephrologist, and as a nephrologist I see a huge shortage of organs for our dialysis patients. It's enormous, and that goes for many other organs. So to enlighten us on this subject and to tell us how well we are doing, how our hospital is doing in terms of organ donation, our speaker today is Sean Paul Harrison, and he has a lot of experience with organ donation. He has been with the Louisiana Organ Procurement Agency, also called LOPA, since 2002 in various capacities. At the present time, he is a physician and donation specialist. So I was wondering what that meant, but he probably knew that. Physician and donation specialist. So, Sean Paul, go ahead.
Thank you, Dr. Braden. Can everyone hear me? All right, well, good afternoon. Who has not received a packet? If you have a raise of hand, anyone? Sean's going to come around and provide those to you all. Again, my name is Sean Paul Harrison. I have been with LOPA for almost 13 years in October. And, the one thing I can say is recently we've been introduced to this physician group. We've probably spoken to over 200 physicians over the last couple of weeks just here at this hospital, which is amazing because in all of my years with LOPA, in working with other OPOs, there's 58 organ procurement organizations throughout the nation, like LOPA. And here in Louisiana, we cover the entire state. And when we go through these conferences with other OPOs, you see that there's lines almost. There's a hospital and there's the OPO, that it's not necessarily always a team that's working together to support families and help save the lives of those that need an organ transplant. And so over the last several months, we've been working on a program that actually was something that you kind of created yourself. We did a physician survey last year, not LOPA. We did it through the Research and Planning Group, RPG, out of St. Louis, Missouri. And we wanted to find out from physicians what they felt, what their perspective was on donation, because we wanted to be a cohesive team that could help these families through death and also the people that were awaiting life-saving organ transplant. So what we found out were three different things. Doctors wanted to be more involved, doctors wanted more follow-up, and they also wanted education. And so through that, we came up with this CME presentation with something that is it's not offered throughout the United States all that often. And your hospital has truly opened their arms and said, hey, look, we really want to work together. And we think that a lot of that has brought the success that you all are having. You all are the #1 hospital in the state in regards to saving lives. We've had 19 organ donors this year and have saved over the lives of 50 individuals. So that's a tremendous thing. And I'm going to say this because not in joke, but in a way that it's been presented to me. When I say that you're the #1 donor hospital, it does not mean that more people die here. What it means is there's a successful process in working with families to support them through the loss of their loved one, and then guiding them through the end-of-life decisions they're going to be making. So I just wanted to give you a little bit of reference of how the CME presentation came together. I'd like to thank you all for having us. It's amazing every time we get to talk to, whether it's one person, but in a group of 50 or more. I also brought with me Vashon Rogers. He's our clinical manager, and he's going to be speaking to you about the management on what we can do to improve the function of organs and the viability for them to be transplanted. And then we also have Kristen with us, who's actually going to give you a story about how donation has impacted her and her family's life. So in your binder that I provided you, on the left-hand side, it has the agenda, and it also has an evaluation form. We are providing CMEs for this particular event. You will receive an email from me, and then also with your certificate. Even if you're not going to be using the CMEs, we would encourage you all to use the evaluation form to give us some feedback so we can continue to improve this. On the right-hand side, you're going to see a communicating brain death pathway, and that's something that we've included to kind of help with the language that we're going to talk about whenever we're transitioning from the end of life to the continuum of life as far as for donation. And then the last thing you'll see is the catastrophic brain injury guidelines, which we refer to as the CBIGs, which is something that has been implemented throughout the United States to improve organ function and increase the number of lives that can be saved. So I'm just going to give you a little overview of donation, and then I'm going to pass it off to Vashon, and then Kristen will share a story, and then at the very end we'll have some questions and answers, and if you all would like to share anything that you all have yourself. So LOPA's offices, our main office is in Metairie, and then we're stationed throughout the state. We've continued to grow. When I first started, we were probably a little less than 100 people, and now we've grown to probably almost 200 people as far as for organ donation, tissue donation, quality. We have a number of people in different facets. Our other big offices are here in Shreveport. Vashon and I are out of the Lafayette office, and we have an office in Baton Rouge, and then we have satellite offices which are in Alexandria, Lake Charles, and Monroe. So the reason why we're spaced out like this is because the one thing that we do every single day and what we want to provide to you all is support. If a family, because when you're dealing with organ donation, everything is very acute. This is not a family who had a loved one that was in the hospital for a couple of months. You're talking about motor vehicle accidents, gunshot wounds, drug overdoses, bleeds, whatever the case may be. These are very acute conditions that are happening to families that they weren't prepared for. So whenever this patient meets a clinical trigger and you all are calling us, we want to make sure that we can be there to help provide support to you all, to make sure that we have a good process in place. In the event that the patient regressed to brain death, that the family would want to withdraw care and see whether or not donation is an opportunity for them. The last thing we want is for a family just to be waiting, you know, especially with everything that they're going through, and also working together with you. And we'll talk a little bit more about that plan. I know that this is the main reason why you all came, is so we could talk about the CMS conditions of participation, because it's, you know, it's something that you probably would like to talk about all day. But it is very important. Whenever I started with LOPA, whenever we were going over like Joint Commission and CMS, you know, I always like to find out, like, what are the reasons? I understand that there's rules and regulations, but it's almost kind of like with I have 3 little boys, and the one thing that I'm always finding out is I need to give them a reason of why we're doing certain things, because then it makes sense. And the reason for the Joint Commission and the CMS regulations is because there's over 130,000 people that are awaiting a life-saving organ transplant. That list continues to rise. You know, if you took the Superdome, or if you took Tiger Stadium, and you included everyone that could sit in that stadium, along with everyone that was tailgating and hanging out in the parking lot, it's more than that. Just to kind of give you a visual on the number of people that are waiting. And there's about 17 to 18 people a day that die because the organs are not available for transplant. So the chances of them receiving that transplant are very few. There's only about 2 to 5% of deaths that can, for someone to become an organ donor. And so that means that we really have to work together to have a good process to support that family and hopefully see an outcome that would help the family as far as for donation, because we've seen what it's done for them and also for the people that are waiting that transplant. So these are just some of the highlights as far as the CMS conditions of participation. Every hospital in the state has a written agreement with an OPO. Here in Louisiana, everyone does have a written agreement with us. Then we also are supposed to be called on every death that occurs in a hospital and any imminent death, which is the clinical triggers, which I'm going to cover in a little bit. And a lot of people that used to ask, well, if there's certain rule outs for certain things, whether it's organ or tissue, why do those particular deaths have to be called in? There's not many rule outs for organ donation. As far as for tissue, sometimes the factors of whether or not it's going to rule out can change. And you know, throughout the nation, we just thought that it was easier. Don't make the hospital staff remember all of these different types of things of when to call and when not to call. If it's a blanketed thing, just make sure they make one phone call, and it's our job to screen and see if there's an opportunity for the family. The other reason is that we want to make sure that we do screen to see if the opportunity exists, because we never want to approach a family for donation if that's not an opportunity. I work with a donor mom who lost her son when he was 16 years old. He was a sophomore in high school. It was the second week of school. And I'll talk a little bit more about this story. I won't take a long time because I can't do it the justice of his mom. And we worked together and actually become very good friends. And she always says, I can't tell you what to say. What I can tell you is what not to say. And one of the things that she always talks about is, don't provide an opportunity for a donor family if it doesn't exist, because then you're taking something else away from them. Because donor families, when they're given that opportunity of donation and they see that as something that can help them, then they latch onto it. And the last thing we want to do is take something else away. So that's one of the main reasons why we screen. Hospital staff must be trained on donation issues. That's what we're doing today. We continually work with the staff. We do new nurse orientations. We do one-on-ones. We provide presentations. We do, one of the biggest, I guess, probably opportunities for us to educate is when we're on site, when we're doing a case or we're on a referral, because it's real-time questions that things can occur. Because right now, if I asked you, you have any questions, I'm sure there would be some, but maybe when you're actually involved in a case, that's where a lot of questions come up that apply to the process that we can answer. Any individual that provides information of donation must be trained designated requester. All of the hospitals in their agreement, they have chosen who their designated requester is. Who is the person that is going to speak to families for donation? And every hospital has made LOPA their designated requester. There's a couple of reasons for that, and we'll talk a little bit more about it. The main reason is that's what we do. 24 hours a day, 7 days a week, 365 days a year. However long the family needs, that's what we have for them. It's not that you all wouldn't do a wonderful job. That's what you're in this for, is to help people. It's because whenever we're on a referral and we're speaking with a family, we're not just there to talk about donation. It may be 12, 16 hours that we've been with the family and donation hasn't even hit the surface, because we're trying to help walk that family through, what that transition really is. Now, it might be very quickly after the family has been told about the death, because they understand the information and they want to know what's next. So it just depends. But we do not isolate ourselves with working with you all, and we'll talk about that with the transitioning and bridging statements. And then it also states that the hospital must ensure the potential donors to be maintained in a manner that maintains the viability of organs. And basically what that means is, if there's an opportunity for a family to donate, then the patient should be maintained as far as for the viability of organs. And we're going to talk a little bit about that as far as the catastrophic brain injury guidelines and how that plays into helping preserve this organ function. This is the clinical triggers. I don't know if this is something that you've never seen before. Every state, their OPO and their hospitals work together on what is the clinical triggers for a patient to be called in as an organ referral. And basically, it's a patient that has suffered a non-survivable brain death injury or brain injury, that is on a ventilator and has a Glasgow Coma scale of equal to or less than 5, or there's a discussion of possibly withdrawal care. If any of those things are met, then the 800 number is called. We get some basic information, and then the coordinator will dispatch a family advocate to come out and get additional information and talk with the staff about the plan moving forward. Team huddle, this was a concept. This is not actually where you see on Sundays where the football teams get around and do that, but it's something to kind of give you that visual. I think the biggest thing with this is the fact that it is a team. If anything that you take away from this is, I want you all to know that, what our vision is to have a cohesive group of individuals working together, physicians, nurses, pastoral care, respiratory, LOPA staff, everyone, to be on the same page and knowing, what we can do for this family. So basically what the team huddle is everyone that's involved in this patient and family care. And, we talk about what the plan is. What's the family's understanding? What's the physician's plan on possible brain death testing? Maybe, they're planning on doing a cerebral blood flow study in the morning. Maybe the nurse is saying, the doctor has spoken to them about, the non-survivable brain injury and the imminent brain death that this patient may have occurred, but the family is in denial. So, we want to know those things, because the last thing we want to do is go and speak to a family about donation, or anyone else to speak to a family about donation, when the family's not ready. Because there has been times when we've actually gone into the room and we've, maybe opened up, this was something that occurred a long time ago, and that's the reasons why these huddles are important, but you're talking to the family about their death, what is your understanding, what did the doctor tell you, and that type of thing, and they're not even understanding that this patient's dead. And brain death is very different visually in what most people perceive death to be, because you're on a ventilator, So your chest is still rising and falling. You still have that color. You're still warm to touch. And for some families, they see that as a coma. They're going to wake up and those types of things. And so it's important for us, as a hospital team and for us, to make sure that we're having a consistency in that message in delivering and making sure that they understand, those reflexes. When we did describing what the apnea test truly was. Sometimes the doctors actually have them in the room when they're doing that neuro assessment. So they can visually see, when they checked the pupils, there was no reaction. Maybe when they were doing, the apnea test, that there was no breaths initiated from that patient and different types of things like that. Or if they did a cerebral blood flow, sure, they're actually showing them, what a normal flow would be compared to what their loved one is. So the family can really understand before we move on to the next step. Because the goal is not to get to the discussion of donation. The goal is for the family to understand what has taken place and then walk them through the end-of-life decisions they're going to make. So, and then the last thing, it talks about a joint approach if appropriate. That is, us as designated requesters, sometimes we will have the physician or the nurse that's been taking care of the family. Some hospitals, they might have a very strong pastoral care team that's involved, and so we have that individual with us just to kind of help support the family, but we're having the actual discussion with them. Again, we do not want to take, the hospital out of this cohesive approach to donation and supporting the family. The conversation of death, basically, we're not going to tell you all what to say as far as for, when you're talking with the family about the death, but, it's just making sure that they understand the prognosis. Like I talked about before, giving a clear explanation of brain death and kind of describing that so they understand it. And then what's probably more important is allowing the family to understand what has taken place. I was speaking to a physician that I befriended out in Seattle, Washington, and when we were talking about these things, because one of the things that probably most people don't understand is that we speak with these families afterwards. It's not just the patient became a donor, and no, we actually have a family services department that is involved with families post-donation, and also sometimes when a family has declined. And there's two things that was a trend that what we've seen and what was been told to us on families. What was one of the reasons why they said yes? The most important reason was the fact of if a person was a designated donor, they had that conversation with their loved one and they knew that is something that they wanted to do and they wanted to uphold that decision. So that's probably the most important things, and that's why we do a lot of community things as far as, getting the word out there and does someone want to be a donor, and having that conversation with your family. It's not something you have to have every day. I don't go home every night sitting home at the dinner table and talking about my death with my kids and my wife, but they do know what my decision is. But the other thing is that it was very important, even with families that had the discussion, for those families that maybe didn't, was that they had time. That the approach to donation is decoupled from the conversation of death. Imagine yourself if a physician went in and spoke to you about your loved one's death, your spouse, a child, a parent, someone, and then after they talked about the death, they went right into the conversation of donation. Sometimes that's not the right process. For the donor mom that I talked about, I'll tell a quick story about her approach, is that her father was on the waiting list for a heart transplant. And her son and his grandfather were very close. And his grandfather never received that heart and he died. And so Libby's son said, "Mom, why didn't Pawpaw receive his heart transplant?" And she said, I guess there's not enough opportunities out there. And at that time, you had to get consent from the legal next of kin. Now, if you have the little heart on your license and you're a registered donor, that is a legal binding decision by yourself. But at that time, he said, "You know what, Mom, maybe we need to get out there and talk more about donations so more people know and so people don't have to go through what we did." Now, again, this was that summer prior to his sophomore year in school. Well, he was in the back of a non-moving truck and he was standing up and he was speaking to a friend that was in a school bus. And he tripped over the back of his book sack and he hit the back of his head. And he went to a local hospital in Lafayette. Now, Libby had 5 children, and she has gotten, she's been to an ER before, and so when she got the phone call, she said, oh, we'll be right there, but wasn't thinking anything tragic. And they're sitting in the ER, her husband, and multiple family members, and the doctor came out in the ER and asked, is Justin's parents here? And they both stood up. And he said, okay, well, you may want to think about organ donation because it doesn't look like he's going to be able to make it. Now, they hadn't even seen their son yet. And they knew what he would have wanted. So even though she knew, she fired that physician and said, absolutely not. I want to see my son. So she was actually approached, and this was a long time ago. Unfortunately, this is not something that happens that often anymore. But it's still important to talk about because she was actually approached, I believe, 3 times before she was finally able, he was admitted to the ICU, and when she was able to spend time with him, she knew that he was gone. And she also knew what he wanted. And this kind of goes back into she can't tell you what to say, but she can tell you what not to say. And donation is a process. It's not a question. It's not about, hey, would you like to donate your organs? It's a process of us supporting a family, regardless if the patient's registered or not, and making sure that that conversation is brought up at the right time. This is the decoupled request. I'm sorry I kind of get off the slides and go into stories. So, but again, just making sure that the 2 conversations are separate. And then the bridging statement. This is one thing that in working with physicians, they've asked a lot of questions. Physicians have said, because it's not the physician's fault. That is not what we're depicting here. The thing that we've made sure is that we've been asked for resources and things that we can do because we know that you're going to be asked questions. I know that if my family was in a situation like that, I'm going to ask, what's next? And so they're not trying to be a challenge. They're just trying to answer a question for the family and just making sure that donation is brought up at the right time. And so this is kind of a generic, we're not scripting you all. We're actually, the statement is just, if they have any questions about the death, I'll give you some time. And when you're ready, we'll have a family advocate, maybe someone that works with our hospital team that's going to come in and help you with some end-of-life decisions. Because we are a part of the team, we are family advocates, and that's what we're here to do. We're actually going to be making cards for you all. It's going to look a lot like this. It's going to have the catastrophic brain injury guidelines that Vashon's going to go over, and it's also going to have bridging and transitioning statements to help remind the physicians if they are in a situation like that, they can reference back to. But our family advocates are on site with you all, and again, we have those team huddles, that we have the conversation that sometimes, Doc, if this is a question that's brought up, this is how you can phrase it to give the family some more time so that we can go in and be introduced later and walk them through that. Again, what do we have to offer? And the consent rates here at the bottom, and I talked about how we have all the time in the world. And because that is our job, and you all have other patients, you have other responsibilities going on. Not that you don't want to be a part of it, but you don't have that 12, 24 hours, unfortunately, to spend with that family. And donation is not, it's not difficult, but there's a lot of things to it. And we want to make sure that we can be that resource. And from 2013, here you can see the consent rate was 63% when we were involved, and then 38% when it was a untrained consent. There's a lot of training that we do go through. We do an effective arts training every year, multiple times during the year, and it's actually actors that come in and they portray these roles, and it is very lifelike, very realistic. And that's no disrespect to families, but we don't want to train on families. But there's scenarios that we give that we know that inside we do, we research and try to find areas that we know that we need to improve on. Maybe it's donation after cardiac death. Maybe, maybe we've had some things with, different questions that come up, like, families like, I don't want to be cut on, and making sure that our staff is very comfortable in answering those questions, the misconceptions and the myths that are out there they're fewer and far between now, fortunately. Most people see donation as something that's very positive. And there's no religions that are against donation, and it's something that's highly supported. But again, the bottom line is the time. And the last story I'll give, and I hate to cut in on Vashon's time, I apologize. And I was at a celebration of life that Our Lady of the Lake in Baton Rouge does, every year. And there was a father there, and it's difficult for me to, I try to put myself in other people's shoes so that I can maybe try and understand, not that I can, what they're going through, but this father had lost his daughter only a couple months prior to this celebration of life, and she was hit by a school bus. And he was telling me his story and everything else, and I was just, I was in complete awe and just heartbroken for this gentleman. And I asked him, I said, can I ask you a question? I said, as a father of 3, and I've never been through what you've gone through, and I hope that I don't, but so that maybe we can help other families, what was the one thing that you think allowed you to say yes, despite everything that you were going through? And he said, that's easy. It was the time. It was the time that the hospital gave me to be with her, to let me just absorb everything that was going on and know that, you know what, my little girl can give to someone else, and hopefully they don't have to be in the shoes that I'm in right now. Whether that's through an accident that caused the life of them, or someone that was in need of a transplant, kind of like Dr. Abreu said, there's such a need for these organs, and especially with kidneys, and we just want to make sure that we can work together as a team to help the donor family and also the recipients that are waiting. So, with that, I'm going to hand you over to Vishon. He's going to talk to you about the catastrophic brain injury guidelines.
Can you guys hear me tonight? My name is Vishon Rogers. I'm the organ recovery manager for LOPA. I've been with LOPA for about 10 years now. I think it's 10 years this month. My background is nursing. My first job was transplant center in New Orleans at Ochsner. We did liver, heart, lung, and combination liver transplants on that unit. And then I moved on more to an ICU setting as a nurse. And I've been with LOPA again for the last 10 years. The thing I want to speak to you guys about today is the catastrophic brain injury guidelines. And again, it's abbreviated called CBIGS, so that term comes up. This is what we're talking about. What occurred a few years ago, and I say a few years ago, about 5 years ago, a group of hospitals and transplant centers in the Kansas City area wanted to know what could they do to help recover and transplant more organs from the donors that we were recovering on. For several reasons. One, as we do more and more transplants each year, the list keeps getting longer and longer because we have better technology now. We're able to treat disease processes better. So these people are able to be on the, not need a transplant, but still live 5 to 10 years, whereas they would have not lived that long before. But they're still being listed. The problem is, as we recover more organs, more people on the list. So we're not balancing out as we should, and we're doing anything we can, and we want to know what we can do to improve that process. If families on the other end who are donating their loved ones' organs want to know, their loved one came in healthy, and they're wondering why we weren't able to transplant every organ that we could from them. And certain things occur sometimes. The process from when a patient becomes brain dead to the process of us actually recovering organs can be a prolonged period of time. Within that time period, some of these organs that were functioning fine before they came in the hospital may have decreased in function for several reasons. One being hypertension, another being, ARDS, another being the patient being extremely dry because we're trying to decrease ICP prior to that patient becoming dead. So there's things that we can do to preserve that organ function. So these physicians got together with the nurses and the OPOs throughout the country, and they came up with some simple guidelines that could be used so that everything could be done in order to give the family the best opportunity as possible to donate their loved ones' organs, and also to help the recipients also to make sure that they can help decrease that transplant list. The purpose of the CBIGS, or catastrophic brain injury guidelines, is basically to sustain organ function to give that opportunity to families. There's 2 types of ways that organ donation can take place. One being brain death. The patient comes in, it could be a traumatic brain injury, it could be a anoxic brain event, but blood flow stops going to the brain dies, that patient becomes brain dead. Legal definition of death throughout the country. Another way that someone can become an organ donor is donation after circulatory death. This is the process that took place prior to the 1960s before patients became brain dead, before they started doing declaration of brain death. Whereas a person suffered a non-survivable brain injury, they're not going to become brain dead, but they won't recover any brain function, and the family has decided we want to withdraw the vent, a terminal wean. There's no meaningful chance of survival. Whenever the vent is withdrawn, these patients is predicted they're going to cardiac arrest and die within an hour or 2 hours. You know, their brain function is very minimal. They may only be breathing over the vent. They may have no other function going on at all. This process we offer to families because families want to know why their loved one couldn't be organ donors. Because this process went out of practice because patients were being declared brain dead. So no one thought that this was necessary anymore, but it really was. So we can still offer the family the opportunity of donation to where instead of withdrawing the ventilator in the ICU setting, we withdraw the ventilator down in the OR, and the patient has to cardiac arrest within 1 or 2 hours. And after their arrest, we can recover organs. Again, we want to recover the organs after someone's brain is dead, whether it's brain dead or cardiac dead. So this is another opportunity for the family to donate. And some of you may have been, if you haven't already, you may have seen this process take place. We do it here at LSU quite often for families, and we do it at every hospital. It's a little bit longer process where LOPA doesn't take over care because this patient is not dead until we go to surgery and the patient actually becomes cardiac dead. And in this process, the physician is really involved because we still need that doc to be down there to order medications, to order lab values, and to withdraw the vent and turn off the vasopressors and fluids when we're in surgery to see if that patient will cardiac arrest. What organs can we recover from brain dead patients? The heart, kidneys, lungs, liver, pancreas, and small intestines. In the process of donation after circulatory death, we can recover the lungs, the kidneys, the liver, and the pancreas. Again, the heart won't be able to be recovered at this point in time because they have the cardiac arrest, so there's going to be a certain element of cardiac dysfunction that's going to take place, so that organ won't be able to be recovered and transplanted. I think they're doing some research in little kids to see if that process can be used, but at this point in time, it's not been successful from a transplant standpoint. The key to everything is going to be early intervention. It's like Sean Paul spoke about earlier. It's all about everybody being on the same page and working together. You're doing your donors to make sure that this patient survives. Unfortunately, we know everybody won't survive. And whenever that's being recognized and you know that's not going to take place, everything has to still be considered to what else can we offer this family? What else can we do? And by maintaining that patient as you normally would and making sure that organ function still is relevant and still good for this patient, we're able to offer something to those families. And we want to avoid deceleration of care. We look at this small graph and it just says, okay, the patient became brain dead. The patient was resuscitated. LOPA was already notified. Everybody's on the same page. The patient was healthy enough to be an organ donor. Resuscitation continued even within that process to make sure the organ function is still good until that patient is declared brain dead and authorization is received from the family and donor management takes place from a local standpoint. Whenever all of this kind of flows evenly, there's no deceleration of care. You still were taking care of your patient as you normally would, and that family will still offer that opportunity of donation. We know what's going to happen pretty much with brain death. It almost follows this path each time. Some injury is going to take place. You're going to see the body fight. You're going to see that increase of blood pressure, increase heart rate. Patient's going to either herniate or partially herniate. Everything drops. I mean, we're fighting, giving them antihypertensives to keep the ICP down, to keep everything, the patient from further stroking, from further organ injury, and then everything hits the floor, and now they're on 3 or 4 pressors. Given enough time, diabetes insipidus will take place. So you're going to have further dehydration of the patient, further hypertension, further volume depletion. And when that happens, the kidneys take a hit, the liver takes a hit, everything takes a hit because of that hypotensive process. So we just want to make sure to avoid the decrease in organ function within that process. So what do we want? And what have the physicians, whenever they discuss this collaborative effort, what were they looking for? Well, we want the nurse on the unit to make sure that accurate vitals and INOs are taking place so that we know immediately this patient is decelerating. What can we do to treat? want to make sure that temperature is maintained. It happens. Sometimes we want everything's performed at taking care of this patient, saving the patient, and nobody really kind of looks at what's going on with the temp, and the patient temperature drops really low. Cardiac function decreases, and overall organ function can decrease also with that decrease in temperature that can take place with a brain dead donor, because they no longer can maintain their temperature. The temperature regulation is no longer effective. Hypertension, for several reasons. The patients, again, lose the effect of ADH because the pituitary gland is no longer functioning properly, not getting that response to the adrenals. Diuretics are used to decrease ICP, mannitol, Lasix, Bumex, whatever. Sometimes the patient just has traumatic blood loss. The patient comes in with a large, could be a gunshot wound, could be a car accident, a lot of bleeding takes place. All of these things contribute to hypertension. Just want to be aware of it. So what do you want to do? Just whatever pressure you want to use it. We'll say dopamine, maintain mean pressure 65 or greater, systolic blood pressure somewhere in the 90s. If that dose gets maxed out, start them on another pressor. Do whatever it takes just to keep everything going for that patient. And sometimes it gets to the point where you're on 3 or 4 pressors, and you're doing everything you can, but you just got to get over the hump. You know, it's temporary. It just needs a little bit of time to stable back out because the patient may be so far behind. If a central line is in and you notice that the CVP is down, or if you have a swine in and you notice that your numbers are going down as yours decrease, then give a fluid challenge. See if fluid is going to help this patient. Start with small boluses. It's not, again, this patient, you know, has suffered a non-survivable brain injury, and at this point, we're trying to maintain the donor to offer that family opportunity donation and maintain organ function. And again, we're not afraid of lever fed. I know sometimes like, oh, we can't use that organ though. Use whatever you need to use to maintain that blood pressure, whether it's epi, lever fed, neo, dopamine. Just keep a good blood pressure for the patient to maintain organ function. Other things to look for. Sometimes, not always, and not that often, but the process of brain death after the catecholamine surge can cause the lungs to not function well either. And you may get a process of neurogenic pulmonary edema can take place. Once it takes place, it's hard to maintain, but just be aware that can take place. Atelectasis can take place because, again, this patient might have suffered some injury, and they're not being turned as they normally would be, and they're on a vent, and atelectasis can take place if even using the best type of treatment. It could be an accident, and you could have thoracic trauma that we need to be aware of, and being on the vent long enough in ICU, you may develop pneumonia if adequate care didn't take place. So we just want the nurse and the physician just to keep doing respiratory function, keep doing pulmonary telemetry, making sure that patient's still getting turned, making sure that ABGs are checked Q24 hours or whatever the hospital's policy is, doing the checks X-ray Q morning when the patient's on the vent. Just so when these things come up, you know what's going on, you know it needs to be treated. Maintaining an adequate tidal volume. I know this one may be a little bit higher than what's normally practiced nowadays, but just making sure that atelectasis and those things don't take place for this particular patient. Make sure a little bit of PEEP is on the ventilator to make sure those lungs stay nicely inflated. And checking the ABG and making sure that the patient is on the best amount of oxygen that the patient needs to be on. If the PaO2 is 350, then decrease that oxygen if that patient is on 100%. Decrease it if it's on 50%. Just enough to make sure that the patient is oxygenating well. I spoke a little bit about DI earlier. Again, it's going to take place. Be aware of it. Know what signs and symptoms to look for. By definition, you know, if the urine output is greater than 500 for a couple hours, and the sodium level is greater than 160, and the specific gravity is less than 1.005, you're looking at this patient going into diabetes insipidus, and something needs to take place. You can give DDAVP as a Q12-hour injection. You can start a vasopressin drip at a low dose, which is a little bit more controllable. Again, if DDAVP is given, just be aware that you may need to stop it if it's clamping off urine output altogether, because again, that'll cause kidney dysfunction also. So it's just good to be aware of that. On the labs, Q24 hours, even though, again, you may not be looking at this patient recover, we still want to know what's going on with the blood count. We still want to know what kidney and liver function is going on. Oftentimes, the CBC and the BMP is ordered, but we don't know what the liver function looks like. So it's nice to know what's going on with that also, so CMP will be helpful. And replace and treat whatever obviously is abnormal. Sort of maintenance fluid, the patient is not on one. If they're on a neural dose at, normal saline at 83 cc's per hour or something like that they may commonly use, at this point you may have to change what fluid is going in because of the elevated sodium level because that patient was being dried out for so long. Or 3% sodium was going, stop that 3% sodium and start them on a more appropriate fluid. If the patient is putting out a lot of urine, again, at this point, we know that the patient is not going to recover. Start to match that urine output with something also so that we can decrease the amount of further hypovolemia that's taking place with this particular patient. We have this case study up here, and this is the actual patient that we had. I think it was Our Lady of the Lake in Baton Rouge. The 36-year-old subdural hematoma came in, found unresponsive by a family member. No neural responses were present in the ER. Patient was on slightly elevated blood pressure, intubated. CBIGs were initiated, so catastrophic brain injury guidelines were initiated by the ER staff because they saw that this patient was probably not going to survive his injury. The patient was declared brain dead within a quick period of time, within 24 hours. Prior to us getting authorization, the patient became really unstable. Developed hypotension, increased urine output, chest X-ray, had pulmonary contusions. This patient we later found out was beat up outside a bar, and that's how they found him. That's what took place in this particular building. They put the patient on multiple pressors. They supported the urine output. They warmed the patient up. They actually had a bag and suction, pre-fully to clear purulent secretions that was going on with this particular guy. And vasopressin drip was started to control the diabetes insipidus. Now, after we got authorization to recover organs, we were able to recover liver and kidneys on this patient. Now, I understand the patient is 36 years old, and you figure we should have recovered more, but just recovering those liver and kidneys, this patient probably would have cardiac arrested if the staff wasn't so aggressive on their treatment. So this guy saved 3 lives. So this is what we're looking at. You might not be able to save every single thing that's going on, but just do the best that we can in order to preserve that function that we can. And ultimately, and this is, I think, a quote from a family member, if I'm not mistaken, we envision a time when no life is lost due to waiting on a life-saving transplant, and with your help, we can get there. And Sean Paul can correct me if I was wrong. Was this from a family member or no? It's part made it into. So I mean, someone out there cares, and we all have family members that are suffering some type of disease process. If we can do all that we can do to help alleviate some of the problems that's taking place throughout the healthcare community with organ donation and helping others, then we want to get to this goal. We may never reach it, but it's a goal, and we're going to strive to get there no matter what. So I appreciate your time. You probably see me on the unit sometimes. I still work in the hospital as an advanced practice coordinator. And if you guys have any questions or anything, please feel free to ask me. You're probably like, nah, we finished for lunch.
I'm sorry, what's the rule now? Say the patient comes in, it says on his license he is an organ donor, and then the parents are at the bedside and they say, no, we don't want to donate the organs. I heard you say the rule has changed recently. I know in the past, all that mattered is what family said.
Well, we'll work with families, but legally in Louisiana, whatever, if the person is an adult, then we can proceed with organ donation because that person has already given permission. And they actually, it was consent. It was, there's no question that they wanted to help somebody by doing organ donation. We'll work with the family though and make sure that they know that's what took place. And more, I mean, we don't run into many situations where a family ultimately is going to say no. You know, they just want to, at the time, I think that what takes place is they have no control over anything, and the quick answer is no. I just want it all to be done. We're ready to go home. We've been here. I just lost my loved one. But ultimately, when they give it a little bit of time, like Sean Paul said, it's not a problem, and they understand that, yeah, this is what they wanted, and actually it's an easy decision because they already made it for me. So we work with families on that, and even families that don't consent, we can still follow up with them and ask them, you know, what were your concerns, or, you know, is there anything else that we can do to make sure that people are more educated on it and that it's not a problem in the future. So we made great strides on that, so it's not really an issue as it was in the past, honestly.
Do families have any control who gets the organ?
They do, actually. Families can direct donate. and they know if that person is listed on the transplant list. Again, we always tell the families, obviously, it has to be compatible. So you may want to donate a kidney to someone, but if it's not going to be compatible with them, that transplant center will make that decision, and they may not accept it. But we'll do our best to make sure that they can. Any other questions? All right, I'm going to introduce Kristen. I did not read your name. She's one of my coworkers, but she also has a very personal story that deals with donation, and that's kind of what brought her to Waterloo. So, without further ado, thank you.
Can everybody hear me okay? Okay, so I come before you today not to speak to you because I'm the best LOPA employee there is, but because I actually have a personal story. And before I came today, Sean Paul asked me to come and speak and asked me if I was comfortable, and I was super nervous. But so I thought, I was like, okay, I'm going to write down some notes, I'm going to make an outline, and then I thought, you know what, I'm just going to speak from the heart, I'm just going to tell you what happened. So hopefully, I find my story interesting. So I work for LOPA. I've been with LOPA almost 8 years. I was 24, my brother was 17 when he was killed. To know my brother was to love my brother. And I know that every family says that, but this is genuinely true with my brother. He was an amazing person, an extremely giving person. He was born with a skin disease that he kept most of his life. It just started to get better when he died. He had severe asthma, allergies, he was on medications, all kinds of stuff. He was bigger, he couldn't help it. He had a lot of different things in his life that could have brought him down and made him, you know, not a good person, not somebody who would want to help others, but it didn't. So he was in high school, and all the kids that used to make fun of him for all these different things that he had growing up, he was the #1 person. Everybody loved him. They loved his personality. They loved who he was. They loved what great things he did for others, and that was for young and for old people. So on November 30th, 2004, just like any other day, he went to school, and he came home from school, and he and I actually had plans that day. And we were going to go and look for him another truck, because he owned 3 cars. He had his home lot with 3 cars, and he was going to get another car. And I, being selfish, decided that I wanted to go hang out with my friends instead of go look for another car for him to have. So I told him no, that I was going to go hang out with my friends, and so he decided that he was going to go to work instead. So I don't know if any of you guys, if a whole lot of y'all are from here or from Houghton. I'm from Houghton. And there's a road in Houghton, and it's called Bellevue Road, and it's a very dangerous road, and there's many lives, unfortunately, that are lost on that road quite often. And his work was down that road. So he was just about to leave, and normally when he left the house, he would get a very, very loud voice. You could always hear him, he's very vocal. And normally when he would leave the house, he would just say, bye, real loud, and slam the door, and off he went. You know, that was just how he always did. Well, today was a little unusual because I could hear him at the door, the garage door, and he yelled as usual, bye. And I didn't say anything, I just listened and expected him to go. And then about a few seconds later, I hear him a little bit closer to me, and he says, bye. And I just sit there, I'm like, okay, bye. And then a few minutes later, he's actually in the door of my room, and he says, bye, Kristen, I just wanted to tell you bye. So he walks out the door, tells me that he loves me, and tells me that I love him. He walks out the door, and about 30 minutes later, I get a phone call. And it's a phone call from his girlfriend, and she said, there's been a car accident on Bellevue Road. Ryan hasn't made it to work, and one of his friends said that he thinks it's him, and they're turning cars around. Bellevue Road's a 2-lane road, and it took up the entire road and the woods surrounding it, and so they were turning traffic around. There was no way to get anybody through. And so I called my mom, and I don't remember this phone call, but she said that the first thing I said to her is, Mom, Ryan's dead. Oh, by the way, my brother's name is Ryan. Forgot to tell you that part. His name is Ryan, and she said, she said that I said Ryan's dead. I don't know why. I don't remember saying that, but I guess deep in my soul and my heart, I knew that he was gone, that something bad had happened. At that exact same time that I called her and told her that I thought he was in a car accident, the state police called her at work, and she had to let me go. So she called me right back and she said, Ryan's been in a car accident. It happened on Bellevue Road, and they just took him by helicopter to LSU. And so, of course, we all rushed up there. We get to LSU, we're waiting in the emergency room for hours while we're waiting for some kind of news. And I just remember it being in slow motion. Everybody walking in slow motion around us, and we're all just sitting there just waiting. And so eventually one of the doctors comes out and he says, it doesn't look good. We're going to transfer him up to the SICU. And once we get him up there, we get him stable enough for you guys to come see, then we'll allow y'all to come and see him. So hours later, when they got him stable enough for us to come, we were allowed to come in and start seeing him. And he was pretty much broken from head to toe. We found out what happened is he was driving on the road. As he was coming around the corner, he was playing on his cell phone. And he was coming around the corner, he actually looks up, and witnesses saw this and told us what happened. He looks up and he notices that he's going off the side of the road. So he overcorrects himself. Well, as he overcorrects himself, he flips his car around and is now sideways on Bellevue Road. At the exact same moment, there is a diesel driving on Bellevue Road going 60 miles an hour, and he's playing with his radio. So he doesn't see a brother. He doesn't slow down. He doesn't attempt to stop. He doesn't even see him. And he hits him. He T-bones him sideways. He hit him so hard that the truck came in, and the brother hit his head on the front of the truck. Witnesses said that afterwards, it kind of flipped him around. He went about, pretty good, I don't know the distance in yards, but he went a pretty good way, flipped his car back around, and landed dead. They tried to get him out, and they couldn't get him out. They had to use jaws of life to get him out, and he was immediately right there here at LSU. When we got up to see him, he was broken from head to toe. But I just remember him being so peaceful looking in that bed. He looked so peaceful and so sweet and so little, but yet he wasn't. And that's what I remember. I don't remember the lines and the blood and all of that. I just remember it just being this peaceful room with him laying there peacefully. And that's not the case. That wasn't how he was. And so that night we were told that he had a pretty good chance that maybe if he went to surgery he'd make it. They do a bone flap, all that good stuff. And that he might make it. And so we're hopeful. So we're in the waiting room sleeping. You know, you stay there all night because you don't know if this person's going to live, this person that you love and you've been with for 17 years is going to live. And so about 3 o'clock in the morning, we come in and a group of doctors come in and they wake us all up in the American waiting room. And they tell us that he's taken a turn for the worse. His brain has swelled. His ICPs were 120 something. And they had just declared him brain dead. And they asked us if we wanted to come in and wanted to see him, and so that we had some decisions to make. And so, of course, we all came in. We called everybody who needed to come up there, and everybody got to go in and see him and say goodbye to him. And we had a decision to make, and that was organ donation. So my family was actually approached or talked to by a family advocate, which is what I do. I'm a family advocate, and her name is Tara Alexander. And she approached my family and talked to us about giving the gift of life through organ donation, and if that's something that we would want him to do. That was a no-brainer for us. The kind of person that he was, the amazing soul that he had, we knew that we wanted to help as many people as we could not have to feel that feeling that we were feeling at that very moment. And so, of course, we said yes. But he also made it easy for us because when he was 14, 15, however they are when they get their license now, when he went to get his driver's license, he told my mom, he said, I want to be an organ donor. And my mom said, no, you're not. You're not going to die before me. You're not going to be an organ donor. We're not even talking about that. You don't want to talk about your 17, 15, 16-year-old dying. And so she didn't allow him to put it on his driver's license because she didn't want him to have to think that way, to have to think that her son might die before her. And so when the time came and the opportunity came for us to give the gift of life, we automatically said yes. We knew that that was something that we wanted to do, that we wanted to help others, and what did we need to do to accomplish that. So We worked with a great team from LOPA, and my brother was able to save 4 lives that day. He gave his kidneys, both kidneys, his pancreas, and his liver. We've actually met his liver recipient. I think he's since passed away because this is 10 years ago. But we met his liver recipient, and it was very interesting to meet and to hear the stories that he had to tell about new things he liked. He never ever wanted to go fishing or hunting. He wasn't that kind of person. Well, that's all my brother did. He was a country boy. And he wanted to fish and hunt and loved mud riding and, country boy things. And so all of a sudden it was interesting to hear him say that I have this strong urge to go hunting, to go fishing. And it was just really cool to see that my brother actually lived on and was a true hero to not only this person, but his whole family and the 3 other people as well. And so we got to say yes and to give the opportunity and to give the gift of life. And so a little while later, I started to volunteer for LOPA, and then I went part-time for LOPA for about 8 months, and then I was asked to come full-time. And it was an easy job switch for me, because to help others in the same tragedy, in the same horrible circumstances that we were in, was something that I wanted to do, and what could I do? And so now I get to come in when it's a tragedy or a loss for somebody, for some family. And I get to come in and I get to tell that family, you know what, there's an opportunity for you. And your loved one has this, and they can be a gift, and to be the gift of life to other people. And more times than not, they're going to want to do that, and they're going to want to say yes. I offer somebody hope in the time of their last time they get to see this person, that their loved one has just died. And anybody laying in that bed, that's somebody's mom, that's somebody's sister, that's somebody's daughter. And I get to give that to that person and that family, is to give them hope and love. So that's why I work for LOPA. That's my sort of donation and how it affected my family, and how it not only affected my family, but each one of us are now advocates for donation. We speak about it as much as we can. We do whatever we can, and we also want to help you guys as a staff to know how to work with patients and families at that time as well. And know that we come in not to bother anybody, not to be vultures, as they like to call it sometimes, and things like that, but to come in as an opportunity for hope for that family, and to help that family and work with that family, because we have the time to do that, and then we get to sit with them and do that. So that's my story of donation. Did any of you guys have any questions? Comments? Thank you for listening.
Well, again, we ran over a few minutes, and we really do appreciate the time that y'all given to us. And as a reminder, if you wouldn't mind filling out the evaluation book with me, you can leave them up here, grab some pens, grab some lapel pins, anything you need. And there's a card in there if you have any questions or comments or anything like that that you'd like to provide to us. Contact us directly. Have a great day.